All right. So, good evening, everyone, and thank you for joining us on March 26th. My name is Cora Peck, and I'm a board member of the Pudendal Neuralgia Association. The PNA offers educational resources and support to individuals affected by pudendal neuralgia, their families, and healthcare providers. If you are interested, I went ahead and put the link to our website. If you want to learn more or if you want to consider donating, the link is in the chat. Tonight, we are excited to have this webinar sponsored by the PNA featuring our esteemed experts, Dr. Richard Marble and Dr. Ashley Gubbels. I'll begin by sharing a little background on our speakers. Dr. Richard Marble is a highly experienced physician specializing in chronic pelvic and vulvar pain. He earned his undergraduate degree from Johns Hopkins University and his medical degree from West Virginia University, followed by residency in obstetrics and gynecology at Hahnemann University. Dr. Marble was on the faculty of Hahnemann University and the University of Maryland, where he held key leadership roles. He later started his own practice focused on chronic pelvic pain and advanced laparoscopic surgery. He is involved with several professional organizations, including the International Pelvic Pain Society, where he served as president. He is a fellow of the American College of Obstetrics and Gynecology and the American College of Surgery. He is also the co-founder of the PNA and serves as a board member. Dr. Ashley Gubbels is a fellowship-trained minimally invasive gynecologic surgeon at Cleveland Clinic, specializing in chronic pelvic pain conditions and is trained in pudendal nerve decompression. Board certified in OBGYN, she is a member of the AAGL and the International Pelvic Pain Society. Dr. Gubbels earned her undergraduate and medical degrees from the University of Minnesota. She completed her OBGYN residency at the University of Nebraska Medical Center, followed by serving in the U.S. Air Force as a general OBGYN. She later completed a fellowship in minimally invasive gynecology, focusing on chronic pelvic pain at St. Joseph's Hospital in Phoenix, Arizona, under Dr. Hibner. Dr. Gubbels has been with Cleveland Clinic since 2022 and became the director of the Chronic Pelvic Pain Program in 2025. She also became vice president of the Pudendal Neuralgia Association this year. Congratulations. Dr. Marble and Dr. Gubbels will answer a few questions at the end, time permitting. To ensure a smooth transition, please submit your questions via the chat, and I will read them aloud when the time comes. Please remember to keep questions general so the doctors can answer. Last but not least, please keep your mics muted and cameras off for the duration of the webinar. So thank you to the both of you, Dr. Marble and Dr. Gubbels, for joining us today, and we look forward to hearing your expert insight on treatment options for PN and when to choose what options. So without further delay.
All right. So we kind of conceived of this idea as a conversation between the two of us and to go over the things that we do in the office and how we make decisions and how we counsel the patients that we see and care for. So after our evaluation, we have to educate our patients about some of these pain disorders and pain concepts, because the more they know and the more they understand, they'll understand the treatment and the more successful we'll both be as a team. So the first thing that I start with is a discussion about pain in and of itself. So currently in the literature, there are three different types of pain that are described. The first one is called nociceptive pain, and you don't have to remember the words, but the concepts. So nociceptive pain you can think of as acute pain, and this is pain the way you're designed. This type of pain serves a role, has a purpose, is protective. It draws your attention to the site of an injury generally, so that you know about it, you're aware of it, you can protect it. But once it heals, you no longer have the pain. It also puts a seed in your memory, maybe don't do that next time. So it has a protective effect. So pain is actually protective from doing things that can injure or harm. So nociceptive pain, pain for the right reasons, pain the way you're designed. There are two types of persistent pain. Persistent pain is completely different. Persistent pain has never been found to have any purpose or role. And it is a dysfunction in the system somewhere in the pain processing system. So there are two types. The first one is neuropathic pain. So neuropathic pain is a type of persistent pain when the pain is due to an injury to the nervous system. Now, an injury to the nervous system can be multiple different things. Um, in the world of pelvic pain, the majority is probably peripheral nerve origin, where there is an injury to a peripheral nerve. So, pudendal neuralgia is an example of this type of neuropathic pain. One of the things to remember is that, unlike nociceptive pain, it does not have a purpose and does not serve a role. It is a dysfunction. The second type of persistent pain, which was first described about 15 years ago, is called nociplastic pain. And this is a different type of pain where the mechanisms of pain generation are the same as nociceptive pain. However, there is an amplification in the system. So any given pain generator will cause a much more intense type of pain than in the normal nociceptive system. And with nociplastic pain, there tends to be a combination of overlapping conditions. So when we see patients in the office, we see a group of patients who have multiple different pain diagnoses, such as fibromyalgia, chronic fatigue, TMJ, chronic low back pain, irritable bowel syndrome, interstitial cystitis. So these are all examples of conditions that we see in a nociplastic type of persistent pain. But there is no rule that says you can only have one. So we have patients who can have all three types of pain, and the management of those types of pain is very different. Um, so that's kind of a general introduction into types of pain, and how we kind of look at it. You want to add anything, Dr. Gubbels?
Yeah, I think another term that patients may have heard would be central sensitization, and that's really that nociplastic pain where the nervous system is just getting better and better and better at sending a pain signal. So, like Dr. Marvel said, it takes much less of a trigger of an exposure to something, or even the system starts generating pain itself. And so the process is called central sensitization. And we know that there's a lot of genetics, environmental exposures, past even abuses or traumas, adverse events that can further prime an individual's system to have more of that type of pain. Um,
So here's a question. You brought up central sensitization. So if a patient develops central sensitization, is that a permanent part of the nervous system, or can that be managed and sometimes reversed?
I think if you get to the person early enough, it's definitely can be a reversible process. It's actually a process that occurs in sort of that natural acute pain that should revert itself. There are changes that happen in the nervous system that eventually we lose the ability to put the brake when we start to lose neurons that inhibit signals. And then it's thought to be permanent. Of course, we are really in our infancy still of understanding chronic pain and these conditions, but that's where some of these centrally acting medications can be really helpful in sort of turning down the dial of that amplified pain syndrome.
So before we get to medicines, are there any things that are not medical or surgical that help patients with persistent pain?
So I think, as you stated, the first is understanding what's happening in their body. I think that educational piece, it's very easy to be fearful of a thing that you don't understand. And again, let's face it, we're even as physicians, we're really not taught a lot about pain. And that's why our patients end up with doctors who aren't able to help them as well as would be ideal. So I think understanding the processes that are happening in their body, number one, can be very, very helpful. And then number two, it's finding what are the things that seem to be triggering my pain. Am I able to find ways to protect myself from that? I.e., if sitting is causing pain, are there different ways that I can sit? Is there a set duration that I can avoid that trigger before it becomes too bothersome? Use of different pillows, things like that we talk to our patients about when they're first coming to us.
Okay, a couple of other things that I always mention is some of the behavioral modifications, and this is not necessarily what people think is behavior, but there are a variety of things that can be done that pretty much help pain across the board. And one of those things that's very important is exercise. So in in pain physiology, what initiates pain and what maintains pain over time can be different. And if you become more and more sedentary, then you will experience more pain. So being mobile and movement and some form of exercise really is a very critical opening treatment for people with persistent pain.
Mhm.
Now, exercise has a definition by the American Cardiology Association, which is an aerobic activity that increases your heart rate and respiratory rate, that's maintained for 20 to 30 minutes, 3 to 4 times a week, which can be accomplished by brisk walking. So, brisk walking is actually in the definition of exercise. So, when we say exercise is critical and we recommend that all patients with persistent pain exercise, a brisk walk 3 to 4 times a week counts as exercise. You don't have to be a rock climber or a pickleball player to meet the role of exercise. So, exercise, very, very important. Other things, mood, depression and anxiety, both as an illness, can block what is called descending inhibition, which are messages sent from the brain to the spinal cord that inhibit pain. And both depression and anxiety will block that inhibition. So if a patient has a persistent pain problem or a pain generator, the more depressed they are or the more anxious they are, the more pain they will experience. We don't really believe that depression or anxiety are a cause of pain or an initiator of pain, but they definitely have an effect on how much pain a person perceives. So if you have depression or anxiety, manage them to the best of your ability because that will decrease the amount of pain you experience.
And that's where exercise plays a role for both of those, right? It also helps depression and anxiety, the happy endorphins that both
Right.
block natural pain receptors and help your mood.
It also treats chronic constipation. It is a frontline therapy for chronic constipation, which many of our patients suffer from, and actually was one of the first known causes of pudendal neuralgia. Dr. Robert, who was one of the people in the 70s who really put pudendal neuralgia on the map, was a colorectal surgeon and noticed that a lot of people with chronic constipation had this particular type of pain. So chronic constipation can lead to pudendal neuralgia, and avoiding constipation is definitely one of the treatments. So partly there's a lot of things that can be done that are good for you and healthy. that are not medical and not surgical that can make a difference. So, what would you do after those two things? What's next in your armamentarium to try to get people better?
So I think that's where we start to talking about those other neuroprotective things. So
Mhm.
utilizing, cushions and seating to sort of, augment ability to sit. Um, Avoiding things that are clearly triggers. So constipation, you've already talked about, but our this was originally called syndrome de cycliste. So people that are doing a lot of biking, doing a lot of stair stepping activities that really exacerbate those pains, horseback riding, that understanding that those may be things that you have to now either give up or find ways to modify how you're doing those behaviors to limit the impact on the nerve is usually one of the next things that I'm talking about.
Correct. And there's quite a few of them.
Mhm.
Um, I've noticed over the years that patients who have persistent pain and patients who have pudendal neuralgia, in early on in the process, they have good days and bad days.
Mhm.
And what differs the good days from the bad days tends to be an activity, and there's certain activities that cause flares. And
Mhm.
why do they cause flares? Because they're either putting a compression on the nerve or a stretch to the nerve, and both of those can increase the amount of pain or increase the message that's being fired by that nerve, that dysfunctional nerve.
Mhm.
So identifying what causes flares is very important in learning how to protect the nerve over time. So sitting is a known factor, and really one of the things we look for in the diagnosis is pain with sitting and relief with standing. That's not the only factor, but it is one of the factors. And sitting on a cushion so that you can sit without compressing the nerve, very, very important in long-term management to get patients better. Um, I have found the longer I have done this, that patients do get better and can get better in the majority of cases. So I never think of this disorder as a permanent pain problem because it can resolve in a lot of people.
Mhm.
So nerve protection, things that aggravate the nerve. So squatting, lunging, and repetitive hip flexion. And repetition is important. So for example, if you have an issue with your piriformis muscle and you do a piriformis stretch, if people know what that is, that can stretch the piriformis muscle and improve piriformis pain, but it also stretches the pudendal nerve and can cause a nerve flare. So that type of flexion that puts a pulling on the nerve causes flares. So walking on a flat surface or running on a flat surface typically will not make most people with pudendal neuralgia flare. But if you're on a treadmill and you put it to a 3% incline, that causes people to flare. Walking up hills causes people to flare. So you really want to keep exercise flat and not on an incline. And swimming is an excellent exercise that really doesn't aggravate the nerve. And really, people who have some type of restriction in their ability to exercise, like a bad ankle or a bad knee, can generally do exercise in the water and swim and get adequate exercise. And that helps turn around that central amplification of pain.
Mhm. Correct. Swimming is one of the things, discussed for patients with fibromyalgia, which is sort of, again, a different term maybe for central sensitization. It's highly recommended, as well as for like the Ehlers-Danlos population with the joint hypermobility. So we have a lot of data suggesting that swimming can be very helpful and it avoids the impact of gravity and weight and everything there as well. That can be helpful.
All right. So after that, typically if patients have a lot of pain that interferes with their ability to do what they need to do, and that is one of the things that I use as to measure pain is how does it interfere with your ability to do what you need and want to do? And my goal that I set for patients is get to a point where pain doesn't prevent you from living your life the way you want, so
Mhm.
that you can do the things you need and want to do, and pain doesn't stop you. The goal is not always never have pain, because pain becomes part of life, especially as people age. Um, but really focusing on your ability to function and getting to a place where you're good and you can function and you can live your life, that's the goal.
Mhm. I always tell patients, my goal with, however many conditions per se that we're treating is to take all of these and put them into the tiniest jail cells that we can, so that these are not things that they're having to think about every day. And recognizing that at some point someone may break out of jail and we have to kind of go wrangle them back again, whether that's returning to PT, backing off on certain activities, changing meds, but that it's possible. If we've gotten them there once, we've got hope to be able to do it again. And that cure is not always 100%, but it's how can we get this to um, not be a thing that you're having to think about every day.
And you bring up a good point, and that is when patients have 5 or 6 different pain conditions, that can be overwhelming.
Mhm.
But more and more of the data that's coming out on persistent pain really shows that the way we have always conceived of pain, like I have bladder pain, or I have nerve pain, or I have back pain, that the real pain physiology probably overlaps by quite a bit.
Mhm.
And we know when we deal with patients with multiple conditions that if they have a bladder pain issue and their bladder pain flares, they can feel pain at the opening of the vagina and vice versa. So defining these by organ systems is probably going to change over time.
Mhm.
And the names that we give things are probably going to change over time. So the first one that changed is irritable bowel syndrome. So it is no longer called irritable bowel syndrome. It is now called disorder of gut-brain interaction, because the real alteration is in the messaging back and forth between the brain and the gut that leads the gut to be hypersensitive. So changing the way you think of pain um, makes can help people move forward. I've had patients come in with 2-year history of clitoral pain, uh, and after evaluation, their pain is really coming from the bladder, not the clitoris.
Mhm.
So all the things you may do to the clitoris to try to relieve the pain is not really going to be beneficial if the pain is really coming from the bladder. So I always encourage patients to focus not on the why. Why do I have this? What's wrong with me? Leave that behind. That's not as important as what management or what change is going to make a difference and help you get better. And then once you're doing better and you have your life back, it really doesn't matter what you name it. So focusing on improving ability to function and changing things over time is really the pathway forward. So the
Agreed. It can
next,
be so overwhelming, right, for people to come in and they have suddenly 10 diagnoses and are wondering, how am I ever going to tackle this hill? And I always remind people that it's a common neuroscience that is really feeding most of those. And so that's really for those types of conditions where we're focusing.
right. And a good way to explain that is if you take away the pain, the sensation, what you feel, what are you left with? Because most kind of medical conditions, you have things other than pain. Um, so a UTI you have frequency, you have urgency. All right. But in the pain disorders, it's pain. The pain is the overriding factor. And all of the pain from those different areas run through the same spinal cord processes that are involved in pain processing.
Mhm.
So the next step is usually medicine. So how do you approach what medicine to use for what patient?
I mean, usually they've tried some things by the time they get to see you or I, right? So usually I've gone through what have you tried before? What was the dose that you got to? Did you get to something that is considered a therapeutic dose, or were you having side effects before they got to that? What I would consider, a reasonable therapeutic dose. What were the side effects? What meds are you on right now? How do we optimize those? And then if I'm really starting fresh, I'm also paying attention to what predominant other system issues are they having. So things like amitriptyline, which can be really great, especially for bladder pain, can cause a lot of constipation in some patients. And so if I have a patient who already is suffering with a lot of constipation, that's not going to be my first choice drug. Right. I tend to probably fairly early go to gabapentin just because it's usually well tolerated. And people tolerate that titration better than some of the other meds. But it's I'm really individualizing that as I'm listening to the patient's story.
What do you mean
How
by
about you?
titration?
Titration, basically increasing that medication slowly over time to try to find where we can get to the highest dose that they can tolerate that is ideally helping their pain. If we get to a lower dose and they're tolerating it fine, as long as it's controlling and managing their pain, great. If not, we want to try to take that dose to its maximum limit to see if it's helping. And if it's not, then we titrate back down or we wean the patient off of that drug and try something different. But one of the things I think happens a lot with patients is they come in and they say, well, I've already tried XYZ. And you ask what the dose is, and it was very low. And they said, well, it didn't help. And it may be a dose that's so low, I wouldn't expect it to help. So I think there's also a lot of education there in terms of really trying to figure out how do we slowly increase that dose to something that we would expect to see benefit from.
The other thing is, I see a lot of times, I see the opposite. I see
Mm-hmm.
patients say, I was on gabapentin and that whacked me out. And I'm
Mm-hmm.
like, well, what dose were you on? What did you start with? 300 three times a day.
Mm-hmm.
Well, that's 9 times more than I start with.
Mm-hmm.
I always counsel patients that the key to medications is to find a medicine and a dose that gives you benefit without side effects.
Mm-hmm.
And sometimes being on 2 or 3 medications at lower doses allows you to get more benefit with less side effects. And there's nothing wrong with this.
Mm-hmm.
Okay. It's managing these meds for pain, especially persistent pain, very different than medicines for other conditions.
Mm-hmm.
Um, we don't really have good data that shows what a therapeutic dose is. And the reason for that is that persistent pain, patients can have genetic changes that alter the physiology of some of these molecules that are affected by these medical treatments. And we don't know which genetic alteration a patient has, so we don't necessarily know which medicine is going to be most effective. So we really have to kind of try the meds. We pick the first one to start based on a variety of patient characteristics. As you said, if they have severe constipation, amitriptyline, which is a tricyclic antidepressant, not the one to start with. But likewise, if a patient has depression and anxiety, which is
Mm-hmm.
very common, a medicine like an SSNRI, like duloxetine, can be effective at treating depression, anxiety, nociplastic pain, and neuropathic pain. Um, and that group of medicines, the SSNRIs, many times can have a lower side effect profile than tricyclics or gabapentin and pregabalin. And the
Mhm.
other thing to remember is that these meds were developed for other conditions. So pregabalin really is the only one that was kind of developed for pain. So the starting doses that are given are not the ideal starting doses for persistent pain, and
Mhm.
many times are too high. So the key is start low, slowly go up as long as you don't have side effects, and then find what I tell patients is your best dose. So
Mhm.
you want to find your best dose. So that's a dose that gives you the maximum benefit without any significant side effects. Any other groups of meds that you like to use?
I mean, certainly muscle relaxants. So concomitant muscle pain plays heavily in these conditions, sometimes as the original generator, but more often as a result of whatever may have originally caused the pain. So some meds like Flexeril also actually probably have an SNRI function to them. So may work on the muscle and may work on the nervous system at the same time. Things like Valium, we used to use a lot of, but that's sort of fallen out of favor, just understanding, certainly as a controlled substance, there's a dependence and abuse issues with that. It also certainly modifies patients' sleep, which we know sleep is protective. Getting good sleep is protective from a pain standpoint. So those are other another group of meds that I typically use.
And,
Um,
when muscle pain is involved, which pelvic floor dysfunction and hypertonic pelvic floor dysfunction generates muscle pain, nonsteroidals can be effective. So again, figuring out what components a certain patient has and then trying to match medical treatments for those conditions is a way to start peeling away the layers of pain that's being generated by different factors or different conditions.
mhm.
What are some meds that you try to stay away from?
I mean, I certainly, we have a lot of data that opioids are not good for this type of pain. And we know that outside of just addictive potential, they also cause a lot of side effects, right? Constipation being one of the most common ones that can certainly for pudendal neuralgia patients be problematic. I also avoid like Soma is an older muscle relaxant that can be broken down into barbiturates that can have respiratory depression effects. Um, I would say those are kind of two of the biggest groups for me. The benzodiazepines, the Valium, like I mentioned. Any others that you're thinking of?
No, I mean, the opioids are a big category, and one of the problems with opioids in persistent pain is opioids have two primary effects. One is analgesia, which is pain relief,
Mhm.
and the other one is euphoria, which is feel good. The pain relief aspect of it is okay. The euphoria aspect of it is what's really dangerous.
Mhm.
And it's very difficult for pain patients to differentiate between pain relief and feel good.
Mhm.
So they're really difficult medications to use. We do use them a lot in acute pain. We use them a lot in post-op pain. You use them a lot for breaking your arm. They do have uses, but for a persistent type of condition, I really try to stay away from them.
Mhm. I think the other thing that people often forget about them is the opioid-induced hyperalgesia. So where they actually can make you feel more pain at a certain point. And then what used to happen is people would put higher and higher doses. They would start requiring more. So yeah, in general, something that we try very hard to stay away from outside of those acute pain. And you can certainly be a chronic pain patient that then develops acute pain for some other reason, whether it's a surgery or procedure that we're performing, you break your arm, etc. And those may be appropriate in that time frame, and they may help your chronic pain for a brief time, but it doesn't mean that they're the right choice for a long term.
How about Tylenol?
I mean, I think Tylenol certainly has use in multimodal. It works differently than all of these other drugs. Most patients have certainly tried that, but by the time they've gotten to us, but I do think in a multimodal therapy, meaning using lots of different drugs and trying to keep all of those drugs at the lowest doses that we can, it certainly can be useful.
And also, um, in the rest of the world, Tylenol is very effective and used for most pain conditions. For some reason in the United States, people think it doesn't work.
Mhm.
One of the reasons it doesn't work is if you don't take it on a scheduled around the clock manner, you're not going to get as much benefit as you can. But it really is important not to eliminate or forget it because it does provide pain relief via a different central mechanism, um, and can limit the need to use other types of medications.
Mhm.
So I think that one is something important. Um, all right. What is your thought on how you differentiate vulvodynia from pudendal neuralgia?
Mhm. I think this is always that hard question. I am looking at where the patient is experiencing pain. So, if it's bilateral and it's very much limited to a certain area of skin around the opening of the vagina, the vestibule, that to me is more specific to maybe a vestibulodynia, which really just means pain of the vaginal vestibule. And I think that's a downside to our, as we were discussing earlier, right? How we name pain is right now it's just named on where you're feeling it. And so none of these terms really tell us what the cause is. And so I think there's grouping of vulvodynia that's caused by certain dermatologic conditions, some that may be caused by changes, non-visible changes in that tissue from hormonal things such as birth control, which is well known. And then that you're kind of left with that other group that maybe is more diffuse, harder to sort of explain. And I wonder, is that, early pudendal neuralgia that maybe will progress with time. I also sort of theorize patients that have recurrent UTI or recurrent vaginitis or yeast infections are those actually small flares? If all the workup is negative, right? We're not finding yeast, we're not finding bacteria to explain that. Is that actually small bouts of nerve irritation?
Yeah, I've come over the
Your thought
years,
process.
I've come to think of it as we treat a variety of different vulvovaginal conditions that cause pain. One that I see a lot that unfortunately is not picked up by most gynecologists is inflammatory vaginitis or DIV. This is a condition where there's actually inflammation in the wall of the vagina, and the inflammatory cells release cytokines that sensitize nerve endings. So this is a type of nociceptive pain. This is pain the way you're designed. Inflammation is supposed to cause pain. Um, but once that inflammation is treated, um, a lot of or a particular part of the pain gets better.
Mhm.
That can present as vestibulodynia. Um, I do think there is a vestibular condition or change that causes pain with touch without spontaneous pain.
Mhm.
And I think of that along the lines of an epithelial dysfunction where there's an alteration in the tissue. Um, but pudendal neuralgia in its early form can present just like vestibulodynia. It can also present like recurrent UTI
Mhm.
because the pudendal nerve goes to the distal part of the urethra, and burning with urination can be a symptom of pudendal neuralgia. Also, many times misdiagnosed as recurrent yeast. And
Mhm.
earlier in the condition, pudendal neuralgia tends to cause intermittent symptoms that come and go and may come for 2 or 3 days and then go away. And of course, somebody is diagnosed with something and treated with something, and then they think obviously that was it.
Mhm.
So, really finding out whether they have a vulvar skin issue or vaginal inflammation or alteration due to hormonal changes, um, and managing those parts makes a big difference in being able to determine if it's really a neuropathic type of pain.
Correct. Yeah. Is it coming from the tissue, the skin, or is it actually deriving from the nerve and a compression of the nerve where they're feeling it at the end of the nerve, right? Which
Right.
is really more so what that pudendal neuralgia and entrapment syndrome would present.
How about how do men compare how they present? Do you know much about that?
I'm so I don't see men, but I mean, I guess I did in fellowship a little bit. Sexual dysfunction, certainly a lot more common, I think, in the male population, erectile dysfunction and things like that. Certainly more notable. Um, but would defer to you. I think you
Well,
certainly have
I see men. I
expertise.
see men both
Mhm.
with pelvic pain in general,
Mhm.
and some of the conditions that we see in women, we also see in men.
Mhm.
So, variety of different peripheral nerve injuries, ilioinguinal, iliohypogastric, genitofemoral nerve injuries, which can cause neuropathic types of pain. Of course, pudendal neuralgia, pelvic floor dysfunction. So,
Mhm.
hypertonic pelvic floor dysfunction. Um, and if your
Men
pelvic floor
often,
is
sorry.
tight for a prolonged period of time, that causes nerve compression and then nerve pain, and pain causes fear, and fear causes you to tighten your pelvic floor, and it's a vicious cycle. So we do
Mhm.
see a lot of overlapping conditions in men and women. Varicocele, which is dilated veins around the testicles, is roughly synonymous with pelvic congestion syndrome, which is varicose veins along the ovarian or uterine veins in women. So there's a variety of different pelvic pain conditions that we see both in males and females.
Mhm.
Weightlifting, I think, is a factor that I see and identify more in men than women. So
Mhm.
if they did powerlifting, especially younger in life, in middle school or high school, that can change the bony anatomy around the pudendal nerve and the ligaments and really be a risk factor for later developing pudendal neuralgia.
Mhm.
Okay, next, to block or not to block?
I'm a block fan. I think, it helps delineate. I'm always telling patients, right, our goal is to try to figure out what nerve pathway, whether it's pudendal neuralgia or it's anything else. At a certain point, if we are thinking, how is this pain getting to the brain? Is there a way, if particularly if we've failed other medications, things like physical therapy, et cetera, can I figure out what pathway this pain is traveling? If I can find the right nerve, then I can start to think, what can I potentially do to that nerve to block that signal from getting to the brain? Because if it doesn't get to the brain, you don't know that you're feeling pain. So I think certainly from a quote diagnostic standpoint, blocks are very helpful. In terms of, it's hard. We don't have amazing data to tell us exactly how many blocks should you do? Should it have steroids? What's the frequency that should be? What would be considered optimal? But certainly there are patients that get improvement from what we would say therapeutic injections or pudendal blocks with steroids.
So if
Um,
you take away the diagnostic part,
mhm.
um, I sometimes refer to it as differential blocks.
Hmm.
So you can block the pudendal nerve at the interligamentous location, which is the most common area. You can do more distal branch blocks with ultrasound guidance. You can do sacral nerve root blocks. So these are blocks at different
Different levels
places,
figure out.
different levels between receptor all the way to spinal cord. Um, and that helps differentiate what can be very confusing overlapping causes.
Hmm.
Sacral nerve roots, the pudendal nerve comes from S2, S3, S4, but you can also have factors that alter the sacral nerve roots, and it can present with pain in the same general area, but all the management we do for pudendal nerve is not going to work if it's from a sacral nerve root injury. Um, I do think, though, that pudendal neuralgia and its understanding has changed over time from that doesn't really exist, uh,
Hmm.
back in the early 2000s. Now, for some reason, people know about it. I think we've done a good job educating the public and medical physicians and clinicians alike. But now we seem to be in this, oh, you have pudendal neuralgia, you need a block.
Hmm.
And I don't do blocks on most people if I'm sure of the diagnosis.
Hmm.
If you don't get better over several months doing the more conservative things and using medications and getting your pelvic floor better and all of the things that we do, then a series of blocks or several blocks sometimes can make a big difference and desensitize. But I definitely don't do blocks in everybody with a diagnosis.
Agreed. I don't think it needs to be done early. I think it is when you start looking at those next level treatments, whether you're considering surgery. I see things popping up in the chat around ablation, those sorts of things. You're sort of starting to try to prove, okay, really it's along the path of this nerve. The other supportive care measures have not led to the positive impact that we're hoping. What else can we now do? What's, our third level treatment? So I don't think that every patient needs blocks right off the bat. Again, I think what patients end up in my office usually have done many of those therapies already. And so that may be one of the earlier things I'm recommending. But again, it depends on at what point are they coming to me.
One comment on blocks is um, many different types of practitioners can do blocks, and many practitioners do blocks of a variety of different places. But one thing I have noticed is that a lot of times they will do the block and they will give them a pain diary and they will go home and see if it makes you better.
Mm-hmm.
Um, Especially in a pudendal nerve block, it is very important to know if you have a technically successful block. And most people who do blocks don't do this. Um, if you get a pudendal nerve block, you should get numb and decreased sensation in the pudendal nerve distribution. And if you don't, you probably did not have a technically successful block. And no response doesn't have any meaning in that situation. I keep patients for several hours when I do blocks in the office because I want to know if they get numb and I want to know at that time what it does and what it doesn't do. And
Mm-hmm.
I think that's lacking in the way the majority of pudendal nerve blocks are done, around the country.
Mm-hmm.
And
Agreed.
that makes things confusing, more confusing instead of less confusing.
Mm-hmm. Yeah, there was a study, and I forget the likelihood of getting all six branches when you look at each nerve, and it was astonishingly low, even with guided imaging. But that is something in my notes for patients with their blocks mentioning. Now, if they didn't notice numbness, but they noticed clear benefit, okay, I mean, that's helpful, but I certainly am looking. You should get numb if you numb a peripheral nerve. The other thing that I think is often not well explained to patients that maybe are getting a block ordered by someone other than us, right, is that they go in thinking, I'm going to get this nerve block and this pain's going to go away. And particularly, it's going to come back as soon as that numbing medicine wears off initially. Granted, there definitely are some patients who notice prolonged benefit, and you may notice later a response from the steroid. But if patients aren't properly prepared, then they come in and they say, well, I've had a pudendal nerve block and it didn't work. And then if you're not educated well enough as a practitioner, then you're going to go, okay, well, it's not the pudendal nerve, and you go off on some other tangent when really it was the pudendal nerve, and the patient just wasn't properly educated on what to expect with that block.
Absolutely. Takes a lot of interpretation.
Mm-hmm.
We don't have too much time left, but real quickly, um, how about surgery?
Mm-hmm.
So, I did surgery. I did pudendal nerve decompressions for 10 or 12 years. You currently do them.
Mm-hmm.
When do you decide on that option?
I mean, typically I want to have maximized everything that we've talked about, right? We've done physical therapy, we've tried different meds, we've maximized our non-surgical options, and certainly, other options are ablations, which we don't have a ton of time to talk about, nerve stimulators, and surgery kind of being your sort of more, I guess, invasive approaches. And so that's certainly a mutual conversation with the patient. I want to know that a pudendal block very much clearly resolves their symptoms, because that's the best predictor that we have of whether or not surgery could be successful. Exam findings, if I can put pressure on that nerve in a certain area and find that it triggers that pain, that's certainly also more suggestive that there's a clear compression site. So those are probably the biggest factors that I'm looking for. It's not to say that I wouldn't offer surgery to someone who doesn't. I very much always want the positive response to block. But then it's that mutual conversation of what do we have left? Do we want to give this a go? I think laparoscopic, I've done trained both in transgluteal and in laparoscopic. I think I can see so much more of that nerve pathway, and I actually don't think there's as much disruption to the pelvic floor as maybe we once thought. And if you think about what Dr. Bolin sees, he finds 80, I think he says 80 to 85% being actually above that interligamentous space. And I would say with my early experience, that's correlated. And that's actually, closer to those nerve roots and other areas that I can explore as well for patients that may have a compression higher up.
All right. Well, it's 8 o'clock, so I think now we'll take a few questions. Cora, are you there?
Yes, I'm here. So, what I'm going to do, there are a lot of questions. Originally started to group them a little bit together because there's some that just need some clarification on some points. But I'm going to really quickly ask some general questions. First, do you both offer telehealth?
I'll answer it first.
Go ahead.
Okay.
We do a lot of telehealth, um, but we have to walk a line along certain regulations. Um, and some people bend the rules, and some people bend the rules more than other people. And some people have the ability to bend the rules, and some people don't. Um, Personally, I don't do telehealth for new patients because
Okay.
most states feel that you have to have a doctor-patient relationship, and they consider an exam part of that doctor-patient relationship. So I always have to see the patient in the office first, and then I'm willing to follow them up with telehealth. It has some limitations. The first visit, you have to do a physical exam, you have to do things to make the diagnosis. Um, but follow-up visits many times can be done with telehealth. And it's certainly better for patients not to drive 2 hours to get to an office if they don't have to. So that's how I do it.
Mhm.
Um, and I know Dr. Gubbels is a little more limited sometimes.
Yeah, I mean, I feel that way as well. So the Cleveland Clinic requires anyone who's not been seen within our institute. So even if they've been seen in dermatology, but they've not been seen in OBGYN, they have to be seen in person, in state and out of state. Um, and the exam is again critical. And I think it's very hard to lose the nuance of a patient's story by separating out the history taking and the exam. So really getting that all in one period. But that is, again, state regulations, insurance changes coming our way where telehealth is potentially getting scaled back as well. I think it's unfortunate in certain places for patients, but yeah, I do telehealth for follow-up a lot. We at the clinic are allowed to do follow-up even if we're via telehealth, even if we're not licensed in a state. But otherwise, patients do have to travel for that first visit.
Okay. And Dr. Marvel, you mentioned that you'd like to do or you mentioned a lot about the different kinds of blocks. Do you personally do the different kinds of blocks you mentioned?
Um, so yes, um, the first type of block that really was done is a in women anyway is a transvaginal block, and they're fairly easy to do in the office, and um, the pain that somebody experiences is not as much as they think it's going to be in the vast majority of cases. And part of the reason for that is when we go through the vagina and through the ligament, you don't have the nerves in those areas that are designed to pick that up, like you do in the skin. So an IV causes more pain than a block through the vagina. So we do it through the vagina. I do a lot of therapeutic blocks with CT guidance, partly because the person I use for CT guided blocks does pulse radio frequency as a treatment, which I think can be helpful. And then I do some ultrasound guided peripheral branch blocks to try to, identify people that have more focal localized pain. Um, so, we do a variety of different types of blocks. And then we do other nerve blocks, obturator nerve, ilioinguinal nerve blocks, iliohypogastric blocks. So a variety of other kind of nerves.
Okay. And Dr. Gubbels, I can't remember where this was from, sorry. Do you also do Botox injections as a form of treatment?
I do, yes. So definitely for people who have that hypertonic pelvic floor, the tight pelvic floor muscles, that can be right pinching around the nerve. I think it's really important that we maximize the improvement in muscle tension before moving on to more aggressive things like surgery. The biggest issue is whether we can get that covered by insurance. And we're working on trying to figure out how to make a cash pay availability for that here at the clinic. But yes, I think that can be very helpful if we think the primary issue is actually the pelvic floor aggravating the nerve.
So do you believe in uh, Botox specifically for nerve?
I haven't personally done like nerve blocks with Botox. I know, trying to think who in Europe does that. I don't know. What's your experience been?
No, I think it's for neuromuscular.
Mhm,
It's really muscle related,
mhm.
not really nerve related.
Yeah, we do know there's uptake in the nerve when you're injecting it into the muscle, but it doesn't physiologically make sense to me to inject it at the nerve. We need it at the nerve endings. That's where it
I
works.
agree.
So,
And have you ever combined both treatments, or would that be a bad idea because then you don't know if one works or the other one works? That makes sense.
well, both treatments, meaning a nerve block and
Yes,
Botox.
and Botox.
Absolutely. I mean, I think when you're first really trying to understand which is chicken or the egg, sometimes just doing a diagnostic block by itself can be very, very beneficial. Because if you're doing a block and you're aggravating the muscle, not all of that muscle signal is traveling through the pudendal nerve. So you can very much cloud the picture. But then you have patients who feel amazing from their nerve block after their Botox injection, And that may be a situation where I actually am not doing a separate block. But if the more confusing it gets, the better it is to start doing singular procedures to help figure out where again, where that pain generator is, or where is a point in the pathway that you might be able to interrupt it.
And I use Botox specifically to take the muscle tension out of the equation. But I use it as a bridge to get other treatments to do what they need to do. So I think Botox is a way to alleviate spasm and hypertonicity for a period of time to allow other treatments to be effective. I'm not a fan of doing a Botox injection every 3 months for 3 years.
Correct. Agreed. I
Okay.
think at a certain point, I tell patients between injections, so I usually will start out with a series of three every 3 months. By between injection 2 and 3, I actually start to notice the muscles aren't as tight anymore, but they may still be tender. And that's where you start to see Botox not really having as much effect. Not to say that it may not be still part of your future plan, but you're using it to, can you get that patient to be able to attend physical therapy and get through those sessions without the rebound spasm? Can they start to do more? Can they exercise more during that time frame to get improvement?
Okay. Speaking of physical therapy, there was one individual that asked about a rowing machine specifically. And I know you discussed swimming and other things. Would a rowing machine be appropriate or not for a pudendal nerve patient? No.
I would go with no.
And then I had one more individual who asked, how
One,
do I
one quick,
strengthen?
one quick comment about that.
Mhm.
The most important part of getting a pudendal nerve to heal is don't do things that aggravate it. It really is the mainstay of the treatment. I know that's hard for a lot of people, especially horseback riders. I live in horse country, and let me tell you, they don't ever want to stop. But if you keep doing a repetitive trauma to the nerve, it's harder to make progress.
So this might be related then to your explanation. The next person asked, how do I strengthen my hip muscles without irritating the nerve? Is there a way to do it, or would you suggest something like swimming, for instance?
Um, so I phrase it like, what are you trying to get out of it? Right? What is your goal of treatment? So physical therapy from a pain standpoint, very important to alleviate spasm and hypertonicity of the pelvic floor. Um, that to me is the biggest reason for physical therapy. But I tell patients, because I'm old, that nerve trumps muscle. Okay, so if you try to treat a muscle and stretch it and aggravate a nerve, that is a loss because the nerve pain will cause the muscle to be tight. So you can work on muscles, but you try to get the muscle benefit you're looking for without aggravating the nerve. Because if you flare the nerve, it's backwards. You're going to get worse, not better. So, for example, the piriformis, you can do a piriformis stretch, but you do it very slowly and you do less to try to get the benefit. That's one way of altering it.
Okay. And now we have a couple medication questions, yet again for clarification. Dr. Marvel, I believe it was you that brought up Tylenol. At what dosage and how often would Tylenol be used to help with pain?
So, as long as you don't have any liver problems, you can use about 3,000 milligrams a day. So 500 milligrams 4 times or 6 times a day, around the clock, spread it out. Um, and, if you give that a trial for a week or so, and see if it gives benefit, when people really do it that way, they're kind of surprised at how much benefit it can give. But it's going to treat some types of pain, but not others. So it all depends on the type of pain.
And then are there any other long-term risks of using Tylenol?
Um, Not if you stay below those doses, unless you have some other, liver abnormality. But I've seen patients come in and say they take 1,800 milligrams of Motrin, 3 times a day.
Yeah.
And that only gives you kidney failure. It doesn't help pain.
And Dr. Gubbels, someone is asking specifically for vaginal suppositories. Is there a benefit to doing suppositories? And obviously, you can do baclofen suppositories and other options. Is there a benefit between rectal versus vaginal suppositories?
I don't think there's a strong, I mean, we have no data on any of this. There may be faster absorption rectally, but otherwise I don't think that there's any clear benefit one over the other than um, that you may not have the leakage or the discharge with using things rectally, depending on, where do you experience the most pain. If you have a lot of anal sphincter pain, maybe actually trying it rectally is better. But they're all off label. We have very limited data on how they're absorbed, how quickly they're absorbed, how well they work. But I do tell patients, you certainly can try it either way, and see which works best for you.
And do you find with your patients that the muscle relaxants, whether done orally or vaginally or rectally, do they help with clenching the pelvic floor muscles, like, for instance, the obturator internus?
I mean, I think every patient responds differently because we all have our own genetics, kind of like Dr. Marvel was talking. I don't personally notice patients get as much improvement when they're using these orally, as they do, other than the drowsiness factor and that you might fall asleep, and that might help you not clench so much. But you can't do that 24/7, right? So I think, that's why we try using these in a vaginal or rectal manner, that potentially that local absorption may be helping, but we don't know how it works.
So I'd like to make a quick point about the pelvic floor. Um, the the muscle of the pelvic floor, with rare exception, is normal. It's it's being driven by something. So there is some factor that is causing the pelvic floor to be hypertonic. Because when we take patients to the operating room and give them propofol, once they're at a certain level of sedation, the pelvic floor totally relaxes. Um, and that's because it it takes the conscious part of the brain away. Um, Propofol doesn't have any muscle relaxant properties. So once your conscious brain is separated with anesthesia, the muscles totally relax. So the muscle is being driven by something, whether it's pain, because pain will cause the muscles to tighten, whether it's fear, whether it's anxiety, whether it's stress, all those things will cause the pelvic floor to tighten. Um, so getting those things better is the way to get longer lasting relief of pelvic floor spasm or pelvic floor hypertonicity. And that is something that's commonly missed. Okay, you have to try to find what's driving the pelvic floor to be tight.
And Dr. Marvel, I remember you mentioning pelvic congestion. Um, what would you, and yet again, this is might be a little too specific. So if it's too specific, feel free to just say you don't know, or you can't answer without examining the patient. Um, but if someone has pelvic congestion syndrome and they also have PN, et cetera, do you have a determination on which one to treat first? Is there a way to
Um,
figure that
well, yeah. And my answer is you want to treat everything at the same time.
out? Okay.
All right. Because you want to try to identify all contributing factors and manage them all to the best of your ability. Um, there is a thing called vascular entrapment of a nerve, and I have seen that multiple times with the pudendal nerve. but it's not easy to treat. Some really advanced laparoscopic surgeons um, treat some of these vascular entrapments, but when you read their papers, they go, there's a fair amount of complications and should not routinely be done. So, but that's pretty rare. That's not too common. Whereas a pelvic venous disorder, um, we see a lot, especially in women with Ehlers-Danlos. Those two things are correlated with adenomyosis and migraine. So those conditions tend to kind of go together um, and are seen in groups of those.
And do you have any opinion or have you come across Tarlov cysts and do they alter treatment course for either of you?
I'll let Dr. Gubbels go first. You wrote the paper, didn't you?
No.
Oh, you weren't on that paper?
No, Dr. Castellanos did, but so yeah, but my fellowship program, they looked at MRIs, and just as often or more often, the Tarlov cyst was on the opposite side of the patient's PN symptoms. And in general, they're not thought to be a common cause. So they don't necessarily, unless the patient is having symptoms suggestive that there's a lesion higher up, meaning they're going to have symptoms in areas outside of the pudendal nerve distribution. That would then make me think we need to investigate other situations. And right, that's part of what we get these MR neurograms for, is to rule out, is there anything else higher up that could be causing symptoms? But again, if your pain is coming from something such as a Tarlov cyst, you're going to have a distribution that doesn't match the just pure pudendal neuralgia anyway. So I don't necessarily treat them initially if the clinical picture is supportive that this is a more distal, more peripheral pudendal neuralgia. Dr. Marvel?
I look at it a little differently. I think in the end it's the same, but when we evaluate patients with pain, all the things that we see and diagnose as a cause of persistent pain exist in other patients with no pain. Endometriosis, pudendal nerve injury, pudendal nerve entrapment, adhesions, everything. So the key is it causes pain in some and not in others. And the key is trying to figure out, is it clinically related? Small ones are probably clinically irrelevant, but when you get up into 2, 3 centimeters, or if there's scalloping of the bone in the sacrum, then you're getting up to where there's a good possibility it could be related. And that's part of the art. We don't have the science to tell us what to do there. And there's a lot of different opinions, but it's possible.
And then we have this one's yet again a little bit more general. Are there any statistics, percentage-wise, of positive results for decompression surgery? Like, for instance, successful surgery versus, say, same level of pain versus worse pain?
Dr. Gubbels.
So I think when you look at all this, the published papers, looking at all varieties, whether it's transgluteal, laparoscopic, the endoscopic, they all have a range somewhere in 60 to 80% of patients get some amount of improvement. Typically in medicine, we consider 30% improvement a statistically significant value. I know when Dr. Hibner looked at data, and I think his article was in 2010, they quoted about a third of patients got, nearly 100% improvement, a third of patients got better, a third of patients got no improvement, and about 1 to 2% got worse. Again, these are small numbers, so that's where we're limited in this. But I think, again, it's going into a procedure knowing our goal is not 100% cure, our goal is improvement, and that the data, regardless of route, is fairly supportive in the right patient, that you're likely to get some amount of benefit.
But we also don't have long-term data that's good.
Yes. So
So,
that a lot of that data is 1 year, one
1
year.
year may be good, 3 years, 5 years, 10 years, 12 years, we just don't have the numbers for that.
Mhm.
So, what about I know we didn't talk about it, but how effective is implanting stimulators like a spinal cord stimulator, a DRG, or a sacral stimulator?
Um, well, so it depends on the type of stimulator. So I place pudendal nerve stimulators for roughly 10 years, and they could be effective. The percentage of people who would recommend it to a friend or family member was about 87%. Um, DRG could be effective. However, the experts can't even agree on where the sacral dorsal root ganglion is. So putting a lead along it is a challenge compared to the lumbar or thoracic areas. Spinal cord stimulation, because a lot of the dorsal column type stimulators are higher in the system, so they have the potential to. But it also kind of depends on the etiology. So if there's a nerve that's really pinched by an activity, it's going to be hard to overcome that, you know, if there's a severe entrapment. Um, but there's not a lot of providers that do stimulators specifically to the pudendal nerve. Um, so and not a lot of data. But I presented data in Scotland. I can't remember the year, and three of us presented, two from the United States, one from Australia, and the data was almost identical as far as success rates. So there may be a place for it, but one of the issues I had is in today's world, stimulators are made now to be MRI compatible, but the way the rules work is you have to use the standard setup for the standard reason. And if you don't do that, they're not MRI compatible. And people won't do MRIs. So a lot of patients kind of want them taken out so they can get an MRI later. So there's a mixed bag of issues associated with stimulation. Unfortunately, I think it's a great approach, but there are certain things that, those types of things make it less ideal. But I still have 20, 30 people who come in and get their stimulator replaced because their battery's dead. And as soon as it goes dead, they know and they come right in. So it can really be effective in some.
So then I'll do two more questions and then we'll go ahead and wrap it up. Um, a lot of people are asking questions specifically about pulsed radio frequency ablation and can they make PN worse? Um, so if you can answer that one.
Um, so we've been doing pulse radio frequency probably for 15, 20 years. There's a large body of evidence in the literature about pulse radio frequency in general. So pulse radio frequency, and this is specifically pulse radio frequency, is a treatment, it's a non-destructive treatment of the nerve. And in all the different locations that where it's been done, there's it's rare for it to cause any harm. Now, we have seen patients have short-term flares after a pulse radio frequency. But I don't know, I can't think of anybody who had pulse radio frequency that long-term got worse. So that is generally felt, and you can disagree if you like, generally felt to be safe, and not likely going to cause harm, and has better outcomes, it seems, than just blocks alone. in a lot of the data. And that's for different types of nerves in different types of areas. So,
And I'm going to actually combine this one a little bit together. So the general topic is going to be around scar tissue, but just to make sure everybody understands, it says, what percentage of patients are made worse by nerve blocks? And then there's also a question later about decompression surgery causing scar tissue, and if there's any way to prevent or lower the odds of it, I guess. So I don't know who wants to take which part of that.
I'll,
But that will be our last question.
I'll take the block part and
Okay.
then she can do the surgical part.
Okay.
There's a large volume of literature on nerve blocks, and nerve blocks in and of themselves, it is extremely rare to cause long-term harm. The exception to that is if you put steroid in the block. With steroid, depending on the type of steroid, um, if you inject steroid into the nerve, that will cause nerve damage, depending on the steroid. But it is very hard to put a needle inside a nerve. Holding it between your fingers, it's hard to put a needle inside a nerve. So it's not real common, but I have seen it. Um, Blocks, if you don't have an infection or hematoma or something like that, which is really rare, blocks in and of themselves don't tend to cause nerve injuries. And there's, many papers that look at blocks and outcome of blocks, and they all basically say they're safe and they give significant benefit to a percentage.
Yeah, I would agree with that. I do think, in my small N surgically, I have certainly seen people who've been having blocks with steroids for a very long time, being a bit more difficult to dissect that tissue. Do I know that that's exactly from the steroids and the blocks? No, but it seems to, again, make sense. And then from just purely a surgical standpoint, I mean, certainly scar tissue, anytime you're working with tissue, there's a risk of scar tissue. The best thing we can do as surgeons is have good hemostasis. So making sure that there's no bleeding left in that space, because blood is the most common thing that's going to cause scar tissue. So having good surgical technique, being careful around that nerve, and making sure that it's the operative site is dry is really the best thing that you can do. There's, are there people that use adhesion barriers? I mean, I use certain adhesion barriers during endometriosis surgery, but we don't really have good data on any of these. I really am not using in my pudendal nerve decompressions, because I don't want to be putting more things on the nerve when I don't know actually how it's going to interact. The last thing I want to do is cause something to be worse. So I'm not currently using adhesion barriers there.
And I did have a patient that I did surgery on who had a seprafilm granuloma from wrapping the nerve in an adhesion barrier. And on pathology, you could see the nerve just weaving through this big fibrotic mass. So when I learned about peripheral nerve surgery, really one of the keys was you don't want to put any foreign body around or adjacent to or, along a nerve from an adhesion standpoint, like a wrap or anything. So I never did it. I tried to avoid it. Um,
All right. Well, anything else you would like to add at the end? If there's any comments in terms of maybe giving some members some hope, especially those, who've been in it for a really long time. I know we have many members that, have been at it for like 20 years and are still in it. Um, is there anything you can tell them, to, keep their hope, if you will, or if you have any ideas?
I think for me, I mean, right, I'm earlier in my career, but the amount of interest, even from when I was a fellow 8 years ago to now, in terms of physicians and residents taking interest in pain conditions has dramatically increased. And pudendal neuralgia is still very niche within that, but my goal is really making sure I'm as educating as many people as I can. They're not going to be doing these surgeries, but they're going to be the people out on the front line educating others and being a referral source so that patients aren't spending 10 years trying to just even get the right diagnosis. They're going to be diagnosed sooner, and hopefully we'll see that have positive impact on the course of disease.
All right.
So I would just say that having been treating pudendal neuralgia for almost 25 years, um, I think most patients have a pathway to get to a really good place. But the pathway that is going to get them there differs person to person. No two people are really the same. And everybody has kind of a different combination of factors. Um, but again, having done this for a long, long time, nerve protection, I think, is the most important part of getting the nerve to heal. Um, and I think that's not written about and not discussed a lot with patients. They tend to think about the blocks and the surgery and the higher tech stuff, but really avoiding the things that aggravate it is the key to long-term benefit. But time is of the essence. Um, the earlier you can um, get somebody started on that pathway, the more likely they are to do well. So time does play a role.
Right. Well, thank you both so very much for taking the time to talk to everybody. I hope we were able to answer most of your questions, and we will also have, I'm sure, more webinars and interviews upcoming. And thank you both for your time. Have a good night, everybody.
All right. Bye-bye.